Hey everyone, welcome back to the New Generation Massage Therapist podcast. Before we get into today's episode, I want to ask you something. When was the last time you added a new modality to your skill set? Maybe you just finished a course. Maybe you're eyeing the next one. I get it, I've been there. But today I want to challenge the idea that another technique is not the answer to what your patients actually need. Stick with me on this one. It might just change how you practice. Let's get into it.
I'm Jamie Johnston, and you're stepping into a new era of thriving as a massage therapist. We're embracing who you are, pursuing what you love, and confidently shaping your practice. We'll challenge industry norms, spark change, and discuss what truly matters. Things like mental health, evidence-based practice, and some topics we've long avoided. Let's create better outcomes for our patients and happier, more fulfilling practices together. Welcome to the New Generation Massage Therapist Podcast.
Here's something that's true in our profession, but most of us don't want to hear. Taking another modality course will not make your patients better. And I know that stings a little bit because we love learning. We love having more tools in our hands, and that drive to keep growing, well, that's not a bad thing. But here's what's actually happening. Every time we add a new manual technique, we're unconsciously reinforcing a belief in ourselves and our patients that better outcomes come through our hands alone, that our touch is the thing that creates change. And the research and honestly the outcomes that I've seen in practice tell a different story. The patients who get better, who actually move out of pain and disability and don't keep coming back for the same problem over and over, aren't the ones who got the best massage. They're the ones who were taught to trust their body again. That's the shift from passive treatment to active, lasting outcomes. So let's talk about why this matters clinically and what to actually do instead. I know we've all seen it before. A patient comes in after an injury or a diagnosis and they're terrified to move. And honestly, we helped create that fear. Now, maybe not us personally, but our profession has. We used to tell people and tell patients to rest completely, to immobilize, saying things like, don't move or it'll get worse. And then there are the practitioners that are still saying things like, if you move, your disc will bulge and get worse, or your pelvis is out of alignment and we need to stabilize it. Every time a patient hears that, we're planting a seed of fear. And for some patients, they've been hearing those seeds planted for years. And that's what's called kinesiophobia, a fear of movement. And it's one of the biggest drivers of long-term disability that we deal with in practice. But this is where we can use something called graded exposure. Graded exposure isn't new. Psychology has been using it for decades to treat things like anxiety and phobias. So in that case, think about somebody who has a fear of spiders. The therapists don't throw a tarantula at them on day one. Instead, they put something like a rubber spider in the corner of a room and help the person get comfortable with it, then slowly and progressively move toward the real thing. So we can do the exact same thing with movement. Graded exposure in our context means slowly and progressively exposing a patient to feared or painful movements where it's enough to stimulate adaptation, not enough to cause harm or prevent healing. We're giving the nervous system some new information. We're saying this movement is safe. Because here's what's actually happening with pain and movement. The nervous system isn't detecting damage, it's detecting threat. And threat is an interpretation. It can change, and it can be changed with the right input. When you find a way for a patient to perform a currently painful movement at a low enough intensity that it doesn't hurt, you're sending the nervous system feedback that the movement is safe. Do that repeatedly, and you start to break the association between that movement and pain. There's a study that was done that I love. They looked at women who were dealing with persistent pelvic pain, and they were divided into three groups. One was the control group, one got manual therapy alone, one got manual therapy combined with graded exposure and pain education. And after 3 months, the group that combined manual therapy and graded exposure had significantly better outcomes in pain severity, fear avoidance, and disability. Manual therapy alone, pretty good. Manual therapy plus movement and education, even better. Another study on persistent low back pain showed the same thing. Graded exposure produced larger improvements in pain-related fear than graded exercise alone. And in some cases, cognitive changes like reduced catastrophizing happened within just 7 days or 3 sessions. Just 3 sessions. So here's the practical side. You don't need a whole new program for this. It fits into what you're already doing. First, just start with education. Help the person understand that pain is a common condition that can be self-managed, not always a sign of serious tissue damage. Next, find out what movements or activities they're actually afraid of. Not what you think they should be doing. What are they worried about? Is it lifting their kids? Vacuuming? Maybe getting back to the gym? Then we want to start with the most tolerable movement, the least threatening thing. And remember, a phrase that I always like to use with people at this stage is to tell them that it's okay to be sore as long as you're safe. Then we want to encourage, encourage, encourage. Positive reinforcement that they can do the movement is part of the intervention. And lastly, we want to make it fun. Make it relevant to their goals. Promote self-efficacy. We want patients moving away from us, not depending on us. And that last one is important. Our goal should never to be a patient who needs us forever. Our goal is a patient who has the tools to manage their own body, because that's what resilience looks like. So here's the question I want to leave you with today. Do you want to keep adding techniques, hoping the next modality is the one that finally gets your patients better? Or do you want to build the clinical framework that actually moves people out of pain, out of fear, and out of dependency? One path keeps your patients coming back for the same problem. The other builds resilient humans who refer everyone they know to you because you changed how they relate to their body. And that's what I'm building towards with everything I create, whether it's courses or this podcast or any other kind of education. So if this episode hits home, I'd love for you to subscribe to the podcast so you don't miss what's coming next, because we're going deep on exactly how to integrate this kind of approach into real clinical practice. And if you're already thinking, I need to learn more about this, stay tuned. I've got something coming that's going to give you the full framework, but more on that very soon. Until next time, keep moving forward and keep helping your patients do the same. Talk soon.